Okay, if I could have everyone's attention, we're going to get started. We don't have our what I remember there as our musical intro, so I'll just use my volume to get your attention. I'm Mike Scharf. I'm the head of child and adolescent psychiatry here for U of R and the psychiatrist in chief of Golisano Children's Hospital. And I'm going to introduce our grand rounds presenters and introduce the topic. Now, as you may notice from the slide that's up on the wall now or on your screen if you're joining on Zoom, we have 4 presenters today, and so we're going to try to be as efficient with this part as possible, but please allow me to set the stage. So in addition to myself with our introduction and discussion at the end, we have our clinical director for child psychiatry inpatient services, Dr. Deanna Sams. We have in order that they're listed here, our medical director, Dr. David Garrison, our one of our clinical psychologists working on inpatient, Dr. Taylor Steeves, and our senior mental health therapist for inpatient, Aubry Ball. We're very excited to present today about the rapid stabilization pathway. This is a care pathway for inpatient. And in terms of setting the stage, and what I would invite people to think about as you're hearing more, we have really in child psychiatry here tried to recognize both our regional and, if you will, population health responsibilities and position, as well as try to make sure that the time we have and how we spend it with patients on the unit is as effective as possible. So you'll hear some things that might challenge some of the checky boxes or the automatic that you check or the automatic things you tell people when they're admitted. Because again, we're trying to provide family-centered, trauma-informed, evidence-based care. I think everyone knows that we are the only regional inpatient unit. We have 24 potential active beds, depending on how the unit milieu is at any point in time. The total census can fluctuate some. Right now, our unit is full with 7 people boarding for admission. So we do have to deal with sort of being over census regularly. And with the implementation of this pathway, not only have we decreased boarding, but we increased the total number of admissions we did from just over 600 in a year to 700 the first full year it was implemented. So without further ado, I'm going to hand off to Dr. Deanna Sams.
Thank you. We don't have to. Hi, everyone. Thanks for coming. We will talk a little bit about what this pathway is and what it looks like, and then get into some of the follow-up and some of the kind of things that have segued from this project. So we started this, Dr. Garrison and I, in 2018, pre-pandemic, and as really as a pilot. And so we developed this really short 3 to 4 day inpatient interventions for kids specifically admitted with a presenting crisis, usually a suicidal crisis, and their families. And that's a really important part that we're going to talk about as we go through. These kids would receive 2 to 4 hours of individual and family therapy daily. And the focus is really on a creative, non-clicky box, values-based safety plan and family communication. And Dr. Scharf kind of alluded to some of our goals. When we started, we wanted to improve quality of care and creativity of our safety planning to make those safety plans more usable and engageable for teens and their caregivers. But we also had a broader systems goal, which was to increase access to care and decompress CPAP by being able to have kids leave in a shorter amount of time. And our hypothesis was we could do that with increased service over a shorter amount of time and do it just as safely. We could reduce length of stay to decompress the CPAP and the system, and also to avoid over-attachment to the psychiatric milieu. I think any of us who have worked on an inpatient unit know that there are a lot of benefits, but also undeniable risks that come with admitting a child or adolescent to an inpatient locked unit. And so our pilot, which was 2018, 2019, we had 30 kids that participated in the pilot intervention group. and 89 in the comparison treatment as usual group. And I was the therapist and Dr. Garrison was the attending. And we had 30 patients participate in our pilot version of RSP. We found that they had a significantly shorter length of stay, and that actually meant, from a systems perspective, that one RSP bed could actually replace 1.5 traditional inpatient beds. So the access to care was greatly improved. And I think the most important thing that we were looking at is are we able to do this safely? This really short length of stay. And so what we found was that these RSP kids weren't admitted any more frequently than their treatment as usual counterparts up to 90 days post-discharge. And that was for CPAP presentations and readmissions to the unit. So with that data, we were able to expand and hire the team that we have today. Some folks, I think, are joining us on Zoom as well. So we have a psychologist, we have 3 therapists, and we have expanded our capability to have up to 6 RSP patients at a time. So who are these kids that could benefit? So we've expanded our criteria. So it's not just adolescents, although the majority of our population is adolescents, but from 10 and on, we can consider. Usually it's a suicidal or self-harm presentation, but one of the keys is that it's related to an identifiable crisis. And so this isn't just a short admission. And I think that can be confusing sometimes. This is an admission with a distinct focus on stabilizing a specific crisis with the family, not just the patient. And so diagnostically, the real only exclusionary criteria are, someone that's actively psychotic or manic or has severe ASD or IDD wouldn't be able, once you learn a little bit about the intervention, you'll see why that wouldn't be feasible. Also important is that the family is amenable to a short admission. Inpatient folks know that sometimes parents come in with different expectations of what this admission is going to be. And so we try to set the stage really early on that this is a really short focused admission. The intervention itself has evolved. It's based in acceptance and commitment therapy and narrative therapy, which is beyond the scope of what we can talk about today, but really blend nicely with each other. We integrate DBT and CBT as appropriate for each patient. Key, again, is early and frequent family involvement. Dr. Garrison's going to talk a little bit about what that family meeting looks like in a narrative kind of way, and getting the family on board early is really important. We have intensive daily individual and or family therapy. Usually it's both. One of the big parts of our expansion was that we now have therapists available 7 days a week on the unit, both for RSP patients and our other patients, which is a really unique, as we talk to other children's psych units, that's a pretty unique thing to have therapists available 7 days a week. So that's something we're really proud of being able to do. And we also really upfront and quickly acknowledge with kids and their families the risks, the negatives, the limitations that can happen if you're on an inpatient unit too long. So we kind of talk about this sweet spot of long enough, but not too long. So the core of our intervention is the narrative safety plan, and we work on this throughout the admission. You'll see everybody's familiar with the Stanley Brown safety plan. On our unit, we do something a little bit different. All of the information that's in this evidence-based plan is certainly included in our NSP, but in a very different way, which I'll show you in a moment. We really focus on creatively telling each patient's story, integrating their values and coping skills. And we don't focus as much on diagnosis, but we really focus on the unique experience of that patient and their family, and making space to acknowledge that this is a low point, right? This something pretty significant has happened that led you to be in the hospital, but we also really pay a lot of attention to the strengths and values. And so in contrast, these are some examples of what our safety plans look like. Every single one is different. And we really go on what the patient is interested in. So you can see we have a Taylor Swift themed communication plan. Kim Kardashian's doing something down there. We had a family who I believe the parents spoke ASL, and so we integrated that. And so we don't necessarily have a template. We have kind of the same components that are in each safety plan, but it's very individualized to engage the kid and the family in this process. And so the safety plan includes kind of a summary of the therapy work, which is really ACT focused and narrative focused, and really focuses on values and tying the coping skills that we all talk about with our patients to those values that are important to that child and that family. Another really central part of the narrative safety plan is the family communication plan. This is created, usually we start with the kid and then have them work through it a little bit with their family in a family session. I don't know how much you can see the detail, but you can kind of get the gist that we're really trying to improve communication in that green zone when things are going okay into the yellow zone so that our kids can find support from their families before they get into a crisis situation. And before patients leave the unit, they practice this with their family. Like we do a situation, we do some behavioral rehearsal, and they go through it. And oftentimes we tweak it right before they leave. We'll be like, okay, we can fix that right now. That didn't go the way you hoped. We take into consideration the parents' suggestions, which sometimes are very different from what the kid thinks might be helpful. So we really work together to come up with a plan that will work for everyone. And as I showed you before, this is what a standard one kind of looks like, but there really is no standard. We use graphics, colors, visuals, whatever really works for that particular patient. So that is a really short overview of what our intervention is. We really focus on ACT skills for those of you who are familiar, and we integrate things like values, distress tolerance, the risks of avoiding anxiety, all of those kinds of things, making choices that are based on your values and not based on your mood at the moment. And we really do that in the intensive therapy over the course of that 3 days, and it kind of culminates in that plan. So post-pilot, we were able to look at some data to see how our expansion has been going in terms of the impact. So from September 2021 to this past September, we've had 385 kids participate in the RSP intervention. Most of them had depression, anxiety spectrum diagnoses. 78% were admitted from CPEP. That is slowly changing as Brighter Days has opened, and we have more direct admissions right from Brighter Days. So I would anticipate that number actually changing a little bit. You can kind of see the graphs of the mean age, race. And so our length of stay in days, and this is a 7-day-week intervention, our average length of stay is about 3.9. We've had some really short RSPs. In fact, we've had same-day RSPs, which is hours of work, but then they come and go the same day. That's not usual, but it happens. And we don't, on day 3 or 4, say, okay, we've done the intervention, you have to go, right? If someone is doing the intervention and they still need more time, they can stay longer until we are able to kind of slow it down a little bit and get them what they need. So what we found is that we looked at 30, 90, 180 days post-discharge. And similar to the pilot, there were no significant differences between the RSP and the non-RSP groups at 30 days, meaning the kids that stayed for 8 or 9 days didn't come back any more than the kids that stayed with this intervention for 3.9 days. Same at 180 days. And what we found this time with our bigger sample is that at 90 days post-discharge, the RSP group actually had significantly fewer readmissions than the kids who were not, than the diagnostically matched kids who were not participating in the intervention. So that was very encouraging to us. And I will, so we will talk a little bit about post-discharge outcomes. This actually started as a fellow project where we started doing follow-ups for kids that had been discharged from the RSP intervention on our unit. And we looked at patient and parent motivation and utilization of the safety plan, coping and communication, and their overall patient and parent satisfaction. So we looked at this at discharge before they left, at 1 week and at 1 month. And then we sent follow-up surveys via RedCap, or if we weren't getting a response, we tried to reach folks by phone. And we had 74 dyads, so 37 patients and parents, so 74 total. So we use the CSQ-8, which is the client satisfaction questionnaire, to assess level of satisfaction and care. And we modified that. We have a parent and a patient version. And then we also developed a scale to look at motivation to use the safety plan. And this is that narrative safety plan that we developed as part of the intervention. And so we asked patients and parents to do this at the time of discharge after our behavioral rehearsal session. And what was actually really cool is that we got data, but we also used this to go back. If a kid was walking out the door and they were like, I'm not ready to do this, we take a pause and say, okay, you put a 1 on here, like, let's talk about how we can get you to at least a 3. So we were able to kind of use this clinically as well. And what we found is that there was a high level of satisfaction from kids and their parents. And really interestingly, and a little different than what we thought, is that patient motivation to use the plan didn't actually differ between time points, nor did parent motivation to use the plan between time points differ. And so really, there was high satisfaction, and also importantly, maybe even more importantly, the scores for motivation and utilization of the NSP at discharge 1 week and up to 1 month when we surveyed didn't significantly differ. So people were reporting using that safety plan up to a month after discharge, up to daily. So this tells us that it's pretty sustainable. We want to continue to look at 3 months, 6 months, 12 months, like longer outcomes. And I think we'll talk at the end about future directions, thinking about having parent groups to assess the feasibility of the NSP as well, and to kind of support parents in using that. So we have a lot of ideas for the future. So I will pass that off to Aubry.
Hi, everyone, and good afternoon. I'm really excited to talk to you all about this component of our presentation, Caring Contacts. Caring Contacts was born out of our desire to continue this good work, right? A kid comes in, they have 3 to 4 days of intensive therapy. We do such good work. And then traditionally we say, goodbye, see you never. And that's a really hard thing to do, both for us as caring people, but mostly for patients. And we know that the period following discharge from an inpatient psychiatric hospital is when a person is at greatest risk for suicide. And so I'll talk a little bit about what the history of Caring Contacts is and how we've adapted the intervention. But the goal is really to provide some warm, caring support to someone when they're most vulnerable. And so Caring Contacts, it was first established by a psychiatrist named Romano in the 70s. It was actually based off of his own lived experience. And so he was a World War II veteran. And during his deployment, he realized, oh my gosh, letters from my loved ones really feel good. They help me feel less lonely, less isolated, and they really keep me going. And so his groundbreaking study was done for a very long time. It was over the course of 5 years that he sent some very simple typed messages of, I hope you're doing well. And they were aimed at the folks who didn't make it to their follow-up appointments. And what that study found is that within the first 2 years, there were protective effects against suicide. And so since then, there's been many iterations of Caring Contacts. Most of them last somewhere between 6 months and 2 years. And so to find the average, we've decided to do ours for a year, and I'll talk a little bit more about what they look like in depth. But there's been a lot of discussions about what the best way is to contact someone. Is it a handwritten note? Are we calling, texting, emailing? And as you can imagine, there's lots of different opinions about that. But what people really prefer, and what we found to be most effective, is handwritten notes. And one of the biggest concerns that comes up is the attachment to the milieu or the inpatient setting. And what we found is there's just not a risk that's coming up when we do this intervention. There's been very few instances of people reaching out in crisis. And when they do, it's usually a text-based intervention, likely because that suggests some immediacy in response. When you get a letter in the mail, snail mail style, you're not expecting to send one back and get an immediate response. So the nature of the intervention just does not lend itself to be a crisis resource. And so the other important part of this intervention is that we're not telling people what to do, right? We're not sending, here's the Brighter Days information. That's all on their safety plan, and we talk about it before discharge. But our goal is really to honor the connection that the person has that led to all of this work between them and their family to get them in a safe spot. And so ours are handwritten. They're warm, they're non-demanding, and they're really just encouraging. I'll have some examples for what they look like, but we offer a rough template to our clinicians, and they are written by the clinician that the person worked with. If they work with more than one over the course of a weekend or their stay, we either let the patient decide who they want to hear from, we split it, or we just make a clinical decision. For anyone that we're particularly worried about these not being helpful and being sort of counterproductive, we can also have the flexibility to make that clinical decision not to do it. But for the most part, we send 6 letters over the course of the year. They're front loaded in the first 3 months because we know this is when the risk is most elevated. And then we sort of slowly wean off and we give them some warnings. And so to make it easier on our staff, we send them out at either the 1st or the 15th, and their letters get mailed at the closest month-long period based on their discharge date. We do pre-write the messages. Well, I would love to say I remember every detail of care at a year later. I just simply don't. So a lot of times we'll speak to aspects that we've discussed during the course of therapy or in the NSP that are not specifically related to being in the hospital or their treatment. It's did you ever make it to volleyball tryouts? How's your cat? Sniffles. Are they doing well? So really just something warm, encouraging to note that relationship. And so we also leave them unsealed for if any reason we need to change things, if somebody does get readmitted, or if they write back. And we've gotten a few responses. And so when they do respond, we include our reply at the next scheduled letter so that it doesn't become a more intense frequency. Couple examples here. We do always acknowledge their birthday in either the letter before or after, whichever is closest. We might say something like, I hope you had a special day. How'd you celebrate? I hope your transition was filled with all the things you were looking forward to, sleep, self-care. And one recently, I asked if they've learned any new tricks on the skateboard or if winter's getting in the way of that. And we always give them a warning at the second to last letter. Hey, this is my second to last one. It's been so fun to get to write to you. We also let them know in the last letter that it's our last one as well. And so the overall response has been so positive. When we first start talking about it with kids and families, we always ask, most generally, when the work is done, so that they don't feel pressured, like they have to say yes. And the way I usually frame it is, some people find this really helpful and a good reminder to continue the work. And some people say, listen, lady, I never want to think about the hospital again. See you never. Either is fine. And so here's some real life examples of some replies we've gotten. It's good to hear back from you. Every time I see an envelope on our kitchen table, I get so excited. Thank you so much for writing to me. I always get so excited to read them. Thank you so much for the lovely cards you've been sending to me. They really mean a lot to me and always put a smile on my face. And occasionally we get some updates about their treatment that's pretty general. There's one here, I'm doing very well, although I've had some issues here and there, but I've worked past them. 7th grade is going well. We've gotten some about some hairstyle updates, which are always fun. But the idea is it just allows some warmth where traditionally it's very hard to make a new connection with a new person. The kids will sometimes say like, okay, now what? Now I have to share my whole story with someone new. So it offers a nice opportunity. And so our next steps are to figure out, okay, this is nice, people like it, but does it actually do anything? And so our hope is to see if by offering someone continued support and warmth during a vulnerable time, does that actually even further reduce their readmission or representation rates to the hospital? And that would then give us some clues about if their suicidality is reduced. And so stay tuned. We've had about 200 people actually participate in this opportunity. And so I will pass it off to our medical director, Dr. Garrison, for the next bits.
And while they're transitioning, yes, applause are welcome. But we just want to remind people on Zoom, wherever the camera is, I'll try to look at it. If you have questions, don't use the chat, use the Q&A, and we will have time for questions at the end.
I was digging around and I found this slide from a presentation in 2013 that was in this room. And we were talking about the contagion, the crucible of contagion on 49000. And for those of you who've worked in inpatient psychiatry, you know that this is very real. You take very social creatures and you put them in a small space and they really mirror each other. There's just a lot of negative behaviors that are often perpetuated, an iatrogenic risk to hospitalization. So that was happening in 2013. So still going on. But now we have the added pressure of the mental health crisis. There's just so many more kids. So we not only have to come up with better treatment options, but we also have to create space for the patients. As I was thinking about this, though, I was thinking about a different way of thinking about crucible, though, because more of a crucible of creativity. And I was just thinking about like this, all the pressure that we have to come up with something has really, I think, really helped us develop this RSP process. And the main thing about that is our great team. Mike Scharf supporting this for so many years. And then Deanna and I have been working together for 20 years, collaborating on different things. And then we have such a talent cluster of young people, truly, not just with you two, but especially with you two. So it's been really cool. So there's a lot of motivation and pressure. I also think the space is so bad on 49000. You couldn't design it worse, really, to create more contagion. And so, but I guess I like to think that has motivated us even more to come up with this process. So it's a crucible of creativity. So we have to decrease risk quickly. How do we do that? So the first thing that pops up is you got to do a family session right away. If you allow the kid to wander off into the emotional attachments of the hospital, there's so much more of a risk for iatrogenic effects. We call it loss to the milieu sometimes. So with RSP patients, we'll say, did we lose someone to the milieu? But with RSP, like, we're less likely to do that because we're going to be engaging the family right away. And the goal is to enhance that family attachment as quickly as you can. Very different than like the old ideas of psychiatric hospitalizations where, a family would leave a kid somewhere. And then another key piece is this acceptance and commitment therapy approach to really emphasize protective factors. This is a transdiagnostic approach that builds on protective factors. There's already so much built-in emphasis on risk factors, and kids are so suggestive. If you spend all of your time focusing on risk factors, that actually, I think, perpetuates the contagion effects. So we really need to talk about protective factors. Acceptance and ACT Act has really just been a way that's allowed us to do that. I'll say a little bit more about that in a second, but critically, Dr. Sams has shown us all these narrative safety plans. That is the intervention. So we're developing this as they're in the hospital, day 1, 2, and 3, and then that's sort of the final product. And this is so helpful. It becomes a real show and tell in the last family meeting. And so families are so anxious, fearful of their child dying. They want to know that something has happened. This makes a huge difference. And also, it's not just that it's creative and personal, but there's also practice. There's this communication practice thing. So you're actually kind of going through what are the triggers. You're scaling at 1 to 10, and you're really just getting into the trenches on a different level than we do with our usual safety plans. I just want to take a little bit more to talk about RSP and narrative. This narrative was something that's always been an interest of mine. In 2005, I started as a medical student exercise, and it's pretty cool that that's still going on. Thank you, Dr. Cardella. And that was really just developed for medical students as a protective factor for them, because it turns out if you just focus on how to diagnose people when you're a third-year medical student, you might lose some of your empathy and communication skills. So that's sort of obvious to anyone who's. So it's a life story narrative. You sit down and meet with someone as a person, and you tell their life story and you write that up. And so it's a very patient, person-centered process. So that was sort of in our history. And then so as we were coming up with this need for a new program, RSP program, we really folded that in. And in 2018, we started doing these narrative safety plans. And Dr. Sam's always on the latest of the psychotherapies. so this is one of the third wave psychotherapies. There's GBT, mindfulness. We got ACT here. They're all very similar, but it's all about how to get through the moments. And then on the narrative front, like, well, why do we get through it? Like, what's the purpose? What's the meaning? What's going to motivate us? And then in that narrative safety plan, there's the practice, and then there's really an emphasis just on what's gonna be a protective factor in the long run. We anticipate what's going to help them a month from now, 3 months from now. We know a hospitalization can only do so much. We lay that out front. But that's a very common thing we say. You only get so much done in the hospital. Often it's worse if you stay here longer. We're going to brainstorm about what's really going to help you. And that's what we're doing as we're going over this narrative safety plan. And I think this, I can attest. I've seen some of these people in my outpatient practice and follow up, and they do use it. It has a different effect. Not only does it help get people discharged faster, but you hear about them using it later. And how many times have we heard from a patient, oh, I have to do another safety plan? And how many safety plans have you done? Oh, I don't know, 30, 50. And, they roll their eyes. And so this is, we talked about the Stanley Brown a little bit. To me, concerningly, all you have to do is just to test that. And then you could say you've clicked the box. And then the last question on there, it literally says optional. The question of like, do you have what do you care about the most and why do you want to keep living? And people usually answer it, but it's just it says optional, which is so. Obviously, we think that's pretty important. We emphasize that quite a lot. Just a couple of articles here. One of them is the narrative exercise article that was from 2012. But then more recently, there was an article that came out in JAMA last month, which talked about how narratives actually decrease suicide risk. This just came out, so that was good timing to be able to talk about that compared to the approaches that are just more template based or clicky based, but actually goes into a narrative that ends up being helpful on a meta-analysis. All right, I'm gonna skip over that, and I'm gonna skip over that too. How are we doing on time?
Yeah.
We're doing okay. Okay. All right. So when I was in the Chicago symposium, my thing was to talk about risky strengths. I had this risky strength questionnaire, which is we have a phase 1 that happened and we're going to make a phase 2. If anyone wants to talk to me more about that, it became my special interest. These guys were making fun of me that I was a little bit obsessed with it. But I'm happy to talk about that more. I'm just going to talk about it here briefly. And this sort of arose organically in the way we do our family sessions, with the first question, what are your child's strengths? And what emerged, this was noticing this for years, by far the most common answer to that is that someone says that they're emotionally sensitive, they have a big heart, they're an empath. That became like the most common answer. And so we realized that that's something that we can really reframe as a risky strength, because that is a vulnerability that makes you more likely to have depression as a teenager when you're around immaturity and insensitivity. And then we also realized, well, there's other risky strengths. And so just out of family sessions, other things would pop up. And so the real criteria for how we arrived at the final risky strengths was, did it lead to a therapeutic conversation? Does this item translate into something that then we talk about in a family session? And that's what has been happening in RSP sessions and other sessions for a while, where we're able to talk about this strength-based approach and reframe. Do you imagine the level of vulnerability to stigma is at such an extreme place, not only to contagion, but just feeling like there's really something fundamentally wrong with you or your child. There's this opportunity to destigmatize and talk about, well, your brain is not permanently broken, but it's just there's a vulnerability here, and how can we change how we think about that? So, for example, on empathy, you have a big heart. Now let's learn some boundaries. Thinking about it from that therapeutic standpoint. And then this really common in these family sessions. Everyone's really nervous. The parent is like terrified of what's going to. Typically there may have been a suicide attempt or a near one. They're afraid to take their kid home. And so there's this hopeful resonance that happens around this idea of a risky strength instead of broken brain, and that builds up the self-confidence and a resonance with the patient and the family. So this was just something that I noticed over and over again. So I thought I'm going to make a questionnaire about it to see if we can elicit this and see if it could be helpful. And so we came up with 11 risky strengths. Like I said, I'm happy to talk about this with anyone. One of the risky strengths turns out I have, which is hyperfocus. And I was really hyper-focused on this one. I think I do want to come up with a phase 2 of this, and I'd love to be able to talk with people more about this. But you can see how I broke this in this chart down. I broke it down so you've got the risky strength, and then where there's an overlap with a diagnosis, and then how does that lead to a high-yield therapeutic conversation. And so I think this could be useful like as a psychotherapy modality as well, where you take this and you're able to kind of think about destigmatizing brain vulnerability in this way. How much time do we have? Yeah. Okay. I'll just talk about the depression cluster there. So the 3 that come up the most with depression is empathy, which we always talked about. So you have a teenager with high mirror neurons. So you talk about, well, put your oxygen mask on first. And then this is something that ages well. Peers are going to catch up. And this is a very common component of our narrative safety plans. Often we'll have an oxygen mask there, a picture of an oxygen mask. But another really common one is perfectionism. So we talk about, this brutal inner critic. It helps people feel like they can function better, but it leads to a burnout effect. People will have a shutdown paralysis. So we talk about the need for acceptance. This ends up overlapping quite nicely with acceptance and commitment therapy approaches. And then there's lots of people that have depression that have high levels of conscientiousness. It's a good thing to be very conscientious, but it puts you at higher risk for depression. So we talk about having an optimal level of guilt. And also, some people are conscientious more towards others. They might be brutally honest to people, so for them, you need to kind of find the right amount of brutal honesty for others. So not brutal honesty, but so that's just an example of the depression cluster there. I think I'll go on, but I'm happy to talk more about that. So I do have a Star Wars slide on here. Dr. Scharf was worried I might not. Many people will know this scene at the end of episode 4 where Luke has to go in and he has to destroy the Death Star. But at some point he takes off his targeting computer. And the people back at the base are, what's wrong, Luke? You took off your targeting computer. What's wrong? And so he was using the Force. Like he was using his intuition at that point. So I use this metaphor a lot for years with medical students, because we notice that people have a tendency towards one or the other. They tend to be either really intuitive and very person-centered and flowing in their interview style, or they're like really organized. And generally, you just need to develop the other side of that. So we talk about it in that way. But I think that the reason why I bring it up here more is because in our technology-oriented mental health world now, there are so many targeting computers that are taking over. And so that could, potentially that could be a really good thing. Like, so if people really know how to do cool things like acceptance and commitment therapy already, they can write a narrative safety plan. That would be awesome to have a co-pilot that could like help you do that faster. And you could like figure out that that's going well. But if you don't have those skills to begin with, or if you're just so overwhelmed by too many targeting computers, the targeting computer could actually prevent you from doing these important therapeutic works, and you're just kind of being a robot. So that is a real risk that's happening with technology, but also an opportunity to like figure out how to, the co-pilot, I love the co-pilot concept here, so that humans are still in charge. So I think, I also think it's cool to think about too with that, like how can the RSP process work in other settings? I think that's a really interesting thing to talk about, and technology may be able to help with that too. But I'm going to turn it over to Dr. Scharf.
I'm going to talk about next steps really quickly. On
oh, you're going to talk about, okay.
You're going to take questions? Or? Okay. Yeah. So just briefly, because we do want to have time for discussion, some next steps that we're working on. We're working with the Brighter Days folks to see if we can, actually, I'm sure we can, to see how we can kind of morph this into an intervention that can happen in the Brighter Days setting. And so there's a ton of opportunity there. We have kids, as many people know, who come to Brighter Days who need inpatient admission but are able to safely wait at home for a bed. They come back to Brighter Days daily for check-ins while they're waiting. Could we, with those kids, actually do this intervention in Brighter Days so that maybe they, by the time there's a bed, maybe they are no longer in crisis, right? And maybe they don't actually need an inpatient admission. We have started just very sporadically doing booster sessions with the actual inpatient therapist that saw the patient afterwards. So every kid that leaves inpatient obviously has a therapy plan. But sometimes for kids, we've been actually having them meet one of our RSP therapists down in Brighter Days to just have a booster session where they look over, a couple days after discharge, how's it going with that NSP, any changes you want to make, things like that. And that's usually their last contact with the therapist, but it's actually been really helpful for kids who maybe are starting with a new therapist and it's a week later and they need something to kind of bridge it. So that's been a really cool kind of thing that we've done informally and collaboratively with Brighter Days. We'd love to have parent support groups and be able to support parents as their kid is in the hospital and also beyond as they're trying to implement this safety plan. I think Dr. Garrison talked about the further development of the risky strength questionnaire, which is kind of phase 2. That we'd like to use. And it is a very therapeutic tool and we use it in therapy. And then you got the psychologist involved and we're talking about factor analysis and all sorts of stuff. So we're going to do some more psychometrics on phase 2. And then just considering our space, I think we're making the most of what we have. And I think having these kids be able to participate in some program, but really with an emphasis on the family work, has been able to utilize our space in a way that works as best as it can, and also have kids and families be able to spend more time together while they're in the hospital, not less. So I will turn it over to Dr. Scharf.
Thank you. So I want to again invite anyone who's joining us on Zoom to use the Q&A, and I'll be reading questions. I'll also take questions from the room. But before I do that, think about your questions. I want to just make a couple comments sort of to start discussion and really highlight, as I mentioned at the beginning, our intentionality is to provide evidence-based, patient and family-centered, trauma-informed care. That's the priority more than any rules or, to use the Star Wars metaphor, targeting computer. Checklists, including diagnostic criteria, can be very useful and to an extreme stupid. If we think about what's different, what are we trying to guide us? Many of you who've worked with me know I like pithy statements, some of which I make up if I can't find a good one. But I found a couple good ones about this. The first is in the words of Maya Angelou: people will forget what you say, they'll forget what you do or did, but they won't forget how you made them feel. If we're going to really do an intervention in crisis, in inpatient care, and it's entirely intellectual, what do we expect? So the connection, the feeling is critical to I would suggest, any successful outcome. The other is about narrative. Why narrative? Why is a narrative critical rather than just the checklist of the safety plan? And I found a great quote for this. This one's new to me, but not new. It's from Kurt Vonnegut. Tiger gotta hunt, bird gotta fly. Man gotta wonder why. Tiger gotta sleep, bird gotta land, and then man gotta tell himself he understand. If we don't identify and work with people about narratives, they'll make up narratives anyway. We like to talk about confabulation as something that happens in delirium and dementia. It's a version of the human drive to make sense of what we experience. So again, an effective intervention, an effective safety plan has to include elements of narrative. And in some of the details of the intervention, in case you didn't hear it all, I mean, the staffing, having psychologists, having therapists to do individual therapy on an inpatient unit is not common any longer. We're trying to bring it back. Having a 7-day-a-week hospital is critical. And the the idea of the risky strengths, right? I mean, I know Dave will use even more exaggerated terms sometimes, like talking about some of these traits as superpowers. But like with the superheroes we like to watch in movies or comic books, they can also be weaknesses. And so I think this is really neat, but the most important part that I want people to really sit with and think about is the human connection and the feelings. I'm very proud of a lot of the things we've been able to do in child psychiatry to move toward our goal for every child in the region having access to care when they need it, to facilitate reaching their full potential. I think this program is a key element of that. And not only the bullet points you see on the screen, but if we keep taking this to fruition, it challenges the idea of what's the purpose of admission and the criteria for admission. Can we offer the same intervention in ambulatory? I think so, but not for everyone. Are we actually, by having admission be the last resort, not providing critical, maybe even life-saving care for people who would benefit from it just because we can talk people into the idea you'll be safe for the next 48 hours? So I think that it's a critical program just for what it is, and the implications for how we can transform care are really monumental. So thank you for your attention. Let's entertain some questions. I've got a couple on Zoom. I'll read the first one, and then Helen, you'll be next. So Dr. Nazra says, I want to congratulate the team on this amazing work and innovative approach to patient care. Truly refreshing. Oh, I don't have a question, just inspired. Thank you, George. I guess I should have read that before I said it out loud. Helen?
Thanks, George. And hi, I have a brief comment and then two brief questions. Try to be brief. I will say that I have two family members who were children in the last 10 to 15 years who are now better functioning adults because of their time on the pediatric psychiatric program. So I have a lot of affinity for what you do. And those humans are in good places now, and I'll tell you more about them someday if you're curious about them. Two brief questions is, are there differences in kind of your medication management plan? Because this strikes me as a very like intensive therapeutic plan. Is there any analysis you've done regarding the conjunction between that and medication? Do you find you use medication less? Or I was just kind of curious about the integration of medication. And then my only other question is, are there elements of this narrative safety plan that there's been any thought about integrating into some kind of like do you put that like on a phone note or an app or some way where kids of that age group might be able to access it more readily based on kind of their technology nativism?
I can answer that one, and then you can answer the other one. So an app, we talk about app development not infrequently. I don't know that any of the four of us have the skill set to be able to do that, but it's definitely an idea. And more simplistically, we encourage kids, they don't have their phones on the unit, but to take a picture of it and save it in their phone because it does lose something without the visuals. You kind of saw that it's pretty engaging visually. So to just have the skills on there would lose something. But we encourage parents and kids to take a picture of it with their phone so they have it accessible.
Yes, on the medication question. In non-psychotic patients, we do use this sometimes with kids with aggression. So maybe different there where a medication response may have more of an immediate impact. But the time course of medication response for depression is longer than what we're dealing with here. So we really but we frequently will start SSRIs and we'll talk about a time course for recovery. There's always an expectation. The great majority of all of your recovery is going to happen after you leave here. We're just trying to get people safe as quickly as they can and set up a hopeful plan. So maybe this would be different if there were like interventional psychiatry options that would treat depression faster, but we don't have those.
Great. I'm going to read another question. This one's a real question from Zoom. This is from one of our therapists in Brighter Days, Carla Boyce. I'm excited as a clinician about this. My question is with regards to neurodivergent populations and if the risky strengths questionnaire and specifically the items listed there meets their needs as well. I think you're seeing nods. Thematically, the idea of a positive narrative is always going to be helpful. Can you answer specifically, Aubry?
Yes, I will never forget a kid who completed the RSQ. and then immediately came up to me and asked, is this a neurodivergency questionnaire? So I would say it does capture that, and that's one of our goals. And we certainly will talk about that throughout the therapy and the intervention as well, when we talk about how functioning looks different for everybody and the process moving forward. That's really the whole point of the individuality, is we can speak to those strengths.
And I think that in terms of our intention and how to think about it, this maps on extremely well with the whole neurodiversity movement of not even considering these clusters of behaviors or what we call symptoms as pathology necessarily. Meredith.
Hi, thank you for that presentation. It was awesome. I had a question about or if there is data regarding people who refuse RSP, like families that might not, or patients, and also patients for whom the process might be more prolonged than anticipated.
Thank you, Dr. Gansner. Deanna?
Yeah, so we talk about it very, very early with patients. Usually I'm screening kids who are slated to be admitted from wherever they're being admitted to see if on paper they look RSP appropriate. And then when they do, we talk about it with families right away. I think mostly, you guys can weigh in, but I think mostly what happens is a parent might have some concern about that short of an admission when we say 3 to 4 days after often a suicidal crisis. And so we try to kind of go through what this intervention actually is to help them kind of feel better about it. We talk a lot about, the risk benefit of staying too long on an inpatient unit. And usually what happens is we start the process, but we slow it down a little bit to better kind of accommodate the needs of the family. Kids who refuse to kind of engage in therapy or aren't in that place where they can engage in therapy, we really can't do this. Same with sometimes kids will be like, I'm not meeting with my family. And if they come in on day 1 saying that, probably on day 3, they're not going to do a behavioral rehearsal of a communication plan. So we might slow it down a little bit. Yeah. And you had a second part to your question. Did I answer it? Did I answer your question?
Yeah, I was just curious if you've been collecting data on that too, because I would just be interested in how it might be altered potentially for families that maybe have certain characteristics that are making it harder for them, like a lot of expressed emotion in the families. Like I've been to some family therapy sessions that are pretty brutal. And so I can see this going awry for certain dyads or triads.
I think sometimes too, we do like more family work. So if the family isn't ready to take their kid home, like we'll just try and help like work with them more. But I don't think we've ever had a kid actually refuse.
We would probably have put them on our more traditional like length of stay pathway if they were at the beginning saying they didn't want to do it. Yeah.
Yeah, I mean, one of the other things that's been amazing about working with the inpatient team is just actually how good we've gotten at predicting things like aggression, length of stay, and goodness of fit for these for this intervention and related interventions. I'm trying to remember the poster numbers off the top of my head, but it's also replicable. Deanna can't either, but it's in the high 90%, not just Deanna, but then trainees who she trained of how to read a chart predicted with 90-something, high 90% accuracy, who would have aggression, who would have contraindications for different interventions from the point of CPEP assessment. I think that's pretty cool. Maybe another Grand Rounds.
Yeah.
I was going to say that another cool thing about this is the way it's expanded outside of the RSP patients too.
Yeah.
Like with a lot of support. All our patients are assigned a therapist, even the patients that are in the RSP track, and that wasn't the case before we were doing RSP. And that was, people like, well, what about me? What about So we really do try to expand it.
And we've actually, the NSP, that full kind of therapy summary and safety plan does take a lot of like hours a day kind of work and intervention. For the kids who are here a little longer, the therapists that are working with them are still doing kind of a modified values-based safety plan. We call it the family communication and safety plan. So it's kind of an abbreviated NSP. Those kids get seen for therapy 2 to 3 times a week, and they're all working kind of aligned with this. It's just the pace is a little bit different. Yeah.
All right, I'm going to read another question from Zoom, and I believe this is my old friend, colleague, and supervisor, Dr. Singh. How do you make sure your ongoing outpatient intervention complement the outpatient provider's interventions? And after admission, does it not create any confusion with having 2 sets of treatment providers?
Yeah, go
So we always do our best to do a warm handoff. And I think it always goes better when someone is within our outpatient system afterwards because their safety plan goes into e-record and it's easily taggable and findable. We also do make sure for kids who are starting with a new clinic or a new therapist that it gets faxed over. But we usually print out many copies and, I'll make jokes, wallpaper your house with it if it helps. But the idea is that they're also sharing this with their school at the school reentry meeting and that they're also bringing it to their first therapy appointment. And I'll email a template, an editable template to the family so that they can continue to edit it. Our ongoing care collaboration is limited from the nature of inpatient to outpatient. But we have heard from many outpatient therapists that it is a helpful safety plan because it's different and the kid is invested in it. Right? When someone's invested in the work that's reflective of them, they can latch onto it better. And so I would love to also do a study on that someday to see what it's like from the outpatient perspective. But the hope is that they're continuing to edit it ongoing.
Excellent. I think I would just build on that. There's always a risk of, making a plan in one setting and then a handoff and then the plan changes. That's always risk in anything. But when we can continue it, it works well. I think it's also, we can go too far worrying that having another connection with, whether it's the letter that's sent or a meeting, is going to be disruptive to new therapy. In terms of how often that really happens, I think it's actually vanishingly rare, but we do think about it. I know we've talked about it with specific cases. So we do try to take into account if we think that there's a risk. But most of the time, this isn't like you're not contacting them to change their treatment plan. You're contacting to remind and reinforce this past experience. Other questions before we close? Questions from the audience? Yes.
It's okay. Can this be applied to psychosis? And if so, how have you modified it accordingly?
I think, go ahead, you want to go?
No, that's a great setup question.
Yeah, it is.
It is a great setup question. Thank you.
I'm
As it is, but.
very motivated to start an early psychosis stabilization pathway on 49000. We're in the process of working on that and hopefully rolling that out soon. But yeah, for someone who has disorganized thoughts, what are the important components? It's going to be different. But absolutely, we need to come up with the best safety plans for everyone.
That's right.
Right.
And we also do really want, I love the question. I love the idea of trying to think what we've learned and apply it to different things. The details, of course, would be different. Yeah. One thing I don't think we mentioned about rollout is also, we will do this anywhere in the hospital, right? We'll start it in CPEP, we'll start it in the medical units, and we are really trying to move toward one child acute service team with no, boundaries or differences in what people can do. Oh, thank you. Sorry.
Adult, okay.
Yeah, the question is about modifying for adults.
Yes, for
Deanna?
an adult setting, because our adult inpatient units are often predominated by people with psychosis mania, but we occasionally get patients who I think would be a really good fit for something like this in the adult setting, and I think would really well be served by something like this.
That's a great question. My psychologist colleague, Dr. Augenstein, is actually at a conference today, but if she were here, I would just pass it to her. She is working on I can't remember exactly what she's calling it, but really an intensive therapy pathway that would be kind of an adult version of this. It might not come right away with the super ultra short length of stay, but having people kind of be able to identify who would benefit from this and having therapists available, that's been a huge part of what she's been working on. So the answer is yes, it's in progress.
That's awesome.
There's one question on Zoom that I do think we should ask, even though we're at the end of our time, and it's about what is in the words of the questioner, Dr. Ainsworth, do you have data on diversity of the population? Does it align with department's DEI goals, et cetera?
We do have data on diversity of the population, and the data is kind of aligned with what our unit demographic is, but also there's a propensity that we have white females enrolled in this program. And we talk about that a lot and what factors kind of play into that. Access, stigma, institutional racism, systemic racism, all sorts of reasons why that's kind of the demographic that we had. What we've learned from talking with folks who have similar programs, or even folks in partial programs, and I don't know our partials demographics, is that they're seeing the same thing in their demographics, and everyone's kind of putting their heads together to figure out how we can expand access and inclusivity. So great question.
The trends map onto who utilizes pediatric acute services. And I'll recall, you can probably, I'm sure it's posted online, a past grand rounds where we talked about Ian Sarrow and the team from Partial Hospital presented on what biases there were and who the population was. And what they actually found was it was all at the front end of referral. And from referral to whether someone started, when they started, length of stay, there was not any significant differences, which doesn't mean it's not a problem. It speaks to, when we say systemized, just how systemized it is. It's not even, it's at the point of referral before we even meet people that the decks are sort of stacked in this way. So we've got a lot more work to do on that.
I would add too, that because we know it's an issue, we are also a lot more flexible on our criteria into the pathway, right? It used to be if there's a restraint in CPAP, maybe that's something that excludes them from the program. And now we're more thoughtful about what leads up to some of these things, and are more flexible on if a family can't make it in person for whatever reason, jobs, financial barriers, can we do this on Zoom? Can we slow it down? And so there's definitely more work to be done, and we're trying to be really thoughtful about it.
Well, we are all passionate about this topic. The remaining question on Zoom is partially kudos from Dr. Wallace and questioning about how you've developed the skills of graphics and narrative. And Jim will follow up with you individually about that. And we're also all passionate about it. Happy to stay later if people have more questions, but we're going to end for now. Please fill out your evaluations, and thank you for your attention.